I'll also introduce Dr. Manley. Dr. Manley is a consultant neonatologist and is now the inaugural professor and director of newborn research at Mercy Hospital for Women in Melbourne, and is a professor in the Department of Obstetrics, Gynecology, and Newborn Health at the University of Melbourne. He leads and collaborates on large clinical trials to improve the health of preterm and sick newborn infants. And very relevant to today's topic, he led the PLUSS trial and is ongoing longer-term follow-up. So thank you again for joining us all the way from Australia to give us your insight on this trial.
Okay. With that, we'll have Dr. Aung take over the presentation.
All right. Hi, everyone. Can you all see my slide okay?
Yep, looks good.
All right. Hi, everyone. Thanks for joining. My name is Htay Aung. I am a third-year NICU fellow from St. Christopher Hospital for Children in Philadelphia. It is my great pleasure and honor to be here today and be a part of this PLUSS trial discussion. Thank you for this opportunity, Dr. King and Dr. Jane. I'm also grateful that Dr. Manley and Dr. Watterberg are here to share their expertise on this topic. So I'm excited for a great discussion. So let me just go ahead and get started. I have no financial disclosure or conflict of interest. This is the outline I have for you all today. Before I jump right into PLUSS trial in details, I would like to start with some background on the BPD prevention by using steroids in early postnatal period, and then discussion will happen intermittently throughout my presentation as well as at the end of my presentation. So BPD incidents are pretty widely ranged in different regions of the world. Just to put that into number, approximately 780,000 infants born extremely premature annually. Due to our advances on NICU care, 85% of them survive. Unfortunately, half of them who survived ended up developing BPD. So we're talking about huge number here. And BPD incidence has been stable over the past decade or even slightly increased. But the good thing is the upward trend is mainly reflecting the mild form of BPD. But however, I feel like it's stay like really challenging to significantly reduce the BPD incidence overall in general, given that it is a multifactorial disease. So just to review quickly on the pathogenesis, BPD likely result from the complex interaction between developmentally immature lungs with multiple perinatal and postnatal exposure. So we have done a lot of interventions to reduce individual exposure. Among all of them, steroids have been heavily studied given the fact that pulmonary inflammation plays a huge role in BPD pathogenesis. Despite all those multiple steroid trials, we still don't know what's the best way to give steroid yet. So a lot of different routes of administrations of steroids have been evolved. So I want to run down those a little bit. So starting out with systemic corticosteroids. So I want to talk about two big analyses regarding this systemic corticosteroid. So starting with the systematic review that was done by Dryle et al. In 2014, looking at the early benefits of early DEX in the BPD prevention. So early DEX shown to improve survival without BPD at 36-week PMA. However, DEX is associated with a lot of short-term and long-term side effects, including GI bleeding, SIP, hyperglycemia, as well as risk of CP and NDI. So a lot of adverse effects. So it's not the way to go. Adverse effects are too high compared to the benefit that we're looking for. So coming on to second steroid, which is hydrochlor. This is an individualized patient data meta-analysis on hydrochlor by Sheffer et al. In 2018. Dr. Watterberg is actually one of the authors for this analysis. She and her group has studied 4 RCT combined, one of their own hydrochlor trial and Primaloss study from France, and 2 other RCTs combined, looking at almost 1,000 participants, looking at the benefits of early hydrochlor in BPD prevention. So early hydrochlor also shown improved survival without BPD in our extreme preemie, and there were no increased risk of NDI or CP like DEX. However, there is an increased risk of late onset sepsis in our intervention group. So hydrochlor is not routinely recommended for our extreme preemie to prevent BPD. However, that can be used in high risk group. So all in all, systemic steroids effectively treat BPD, but they are associated with harm. So how about inhaled corticosteroid? You'll be able to get that local pulmonary anti-inflammatory effect at the same time, minimizing our systemic side effect. So when it comes to inhaled corticosteroid, NeuroSID trial is a big one. So it's a large multi-center RCT from 9 European countries, looking at our extreme preemie, about 800 of them. And this study showed that inhaled budesonide also improved survival without BPD. However, there were increased mortality in our intervention group at 18 to 22 months of corrected age. So given that significant side effect with the very little benefit, most of the physicians didn't adopt this intervention either. So inhaled steroid is not the solution. So how about instilled steroid? So we can give it effectively all the way to the distal airway, but how do we give it? What's the right to use? Budesonide seems to be a good option, given that it's greater affinity to glucocorticoid receptor compared to other steroids, and also higher ratio of topical to systemic anti-inflammatory effects. So minimizing our systemic side effect. And then when you give budesonide intratracheally, you basically get all the effects that we desire, as well as, high local effect up to a week. So we like that. How about giving it effectively all the way to the distal airway? So one of the route to think about is the intratracheally, and we have surfactant that we commonly give intratracheally in our extreme preemie. So giving it all together might have some benefit. So a lot of animal study has been out. Also some human study looking at the benefits of giving them together. So surfactant effectively deliver budesonide to the distal airway. And when you give budesonide together with surfactant, there's also better alveolar distribution, longer half-life in the lung, so all the good things. And at the same time, we have to make sure budesonide is not interfering with the surfactant effect. So that doesn't seem to be the case either. And they also promote lung maturation, similar to antenatal corticosteroid. I think that's a huge thing. Some moms come in like very early on, not enough time to give antenatal corticosteroid. So by giving that combo, you can promote some lung maturation. So all the good things. Because of all the benefits that have been evident, a handful of small RCTs already been out between like 2008 to 2017, and showing a lot of promising effect in terms of this early intratracheal budesonide mixed with surfactant. So among all those trials, Ya et al. Trial in 2016 seemed to be the RCT with relatively decent cohort size with the well-structured methodology. So I want to talk a little bit more about that trial. So this is a Ya et al. Trial published in January 2016 at American Journal of Respiratory and Critical Care Medicine. This group is actually from Taiwan. They started out with single center pilot study in 2008, and they found the promising effect. So they, added 2 other centers, make it like larger cohort, another center locally from Taiwan, and then the third center is actually from Chicago, USA. So the group, all 3 centers combined, they were able to randomize up to 265 patients and break it breaking it down into 130 extreme preemie in each group. So intervention group will receive budesonide mixed with surfactant, giving intratracheally up to 6 doses of budesonide. And the other intervention group will just get the surfactant only. And looking at their population, their mean gestation age of the infant involved in the studies are 26 and 5, and mean bar weight is about 850 grams. And looking at their inclusion criteria, they include all the very low bar weight infants with severe RDS who were intubated and needing a lot of support with the ventilation, high FiO2 requirement, 50% and above. They were all included, and the intervention were given within the first 4 hours of life. So looking at like very early on with severe RDS with needing a lot of support, those kids were included. And they look at the incidence of BPD as the primary outcome. And this is their result. So there's a significant reduction in BPD in the intervention group, 30% versus 50% in the control group. So there's a big 20% reduction in the BPD. So this is a very promising result. So this call for larger multi-center international trial to confirm this promising effect before we start adopting widely for this intervention in our extreme preemie. That's where our PLUSS trial comes into play, and by Dr. Manley and his colleagues. So the team actually
we can ask Dr. Manley too. So I think it was Dr. Aung presented very nicely about the background of the study and everything. So, and the effect size was huge, almost close to 40% reduction in things. So, yes, we should always do a big study, but can you walk through what was going through your mind, Dr. Manley, while designing the study? Why we need a study? Do we need to select different babies if we adopted? Can you walk us through your thoughts that time?
Yeah, thanks, Viral. That's a good question. I mean, you saw that there's, prior to us designing and conducting the PLUSS trial, we saw the A trial results, which are, really dramatic, aren't they? If we had a therapy that truly reduced death or BPD by a third or halved the incidence of BPD as they found in that trial, that would be practice changing for sure if it was safe. Dr. Aung mentioned the inclusion criteria of that trial and noted that those babies were mechanically ventilated and in 50% oxygen. And whilst we might recognise a population of babies like that in our units, there are also many extremely preterm babies that are not in that similar condition at the time they're admitted to the unit, especially, of course, if they've already had surfactant. And then there's some other things apart from just the sample size. There's been a lot of practice change about how surfactant has been administered, and certainly at this time when we started the PLUSS trial, many units were beginning to use or were routinely using less invasive surfactant administration, even in extremely preterm babies. And also, if you look at the results of the A trial, the mean gestational age of included babies was around the 27-week gestation mark, and the mean birth weight was around 800 or 900 grams. And whilst, of course, that's an important population of babies, we're looking after smaller and smaller babies, of course. And so we certainly wanted to make sure that we did a trial that included the smallest and sickest babies, which had not been included in good numbers in the previous trials. So I think there's at least a few reasons, and there's probably a few I'm forgetting at the moment, but we can come back to that when we discuss the results of all the trials in context.
Thank you, Dr. Manley. Dr. Aung, you can proceed.
Sure. So starting with some PICO, the population the team has looked at is all the extreme preemie less than 28-week gestation, total of 1059 infants from 21 NICU from 4 countries, Australia, New Zealand, Canada, and Singapore. So majority of them are from Australia and a handful from New Zealand, and one each unit from Canada and Singapore, just to get that little breakdown. Intervention will be administrations of budesonide mixed with surfactant intratracheally, and control group where only receives surfactant. And then primary outcome is the team will be looking at survival without BPD at 36-week PMA. And then secondary outcomes are like the breakdown of primary outcome itself and all the other in-hospital comorbidities, and also the serious side effect of intratracheal budesonide. And the recruitment started like 2 years after the YA trial has come out, and it runs all the way like a little bit over 5 years. And then, finally published last year in JAMA. So moving on. So the objective of the team was to investigate the effectiveness of this early intratracheal steroids on survival without BPD in our extreme preemie. And this is the inclusion criteria. The infants need to be born before 28 weeks, and they need to be less than 2 days old. And those infants who were receiving mechanical ventilation, regardless of their vent setting, regardless of how much FiO2 they were requiring. And if they are not intubated, all those non-invasive ones like CPAP, NIPVV, high flow, and they need surfactant. So those kids will be eligible to be included. And if any infants who already receive 1 dose of exogenous surfactant prior to randomization, they are stay eligible as long as the prior dose is not more than 1. Dr. Manley, would you mind sharing how you and your team has come up with this inclusion criteria? Look like really broad, looking at those criteria.
Yeah, I think being pragmatic and broad is really important in neonatal clinical trials, and something I feel as a specialty we could probably do better moving on. And there are arguments both ways. I mean, of course, we need to be thinking about which babies benefit from which therapies as well. But I think in the first big trial of this therapy, really aiming to see if this would be beneficial across the board in extremely preterm babies, we wanted to make sure that most babies were eligible, and this really does mean that most babies are eligible. These inclusion criteria, you can probably only think of a few things where babies might not be able to be enrolled, but you'll note you might be getting to the exclusion criteria, but there are only a few exclusion criteria. And through history, we've routinely excluded small for gestational age babies, the most immature babies, the smallest babies, and in fact, they're the ones that really stand to benefit the most, and we need more evidence in. So we were careful not to exclude too many babies. The key point, going back to the inclusion criteria, is at the bottom, and we really talked a lot about whether we would still enroll babies who'd been given surfactant either in the delivery room or very early in their NICU stay, where of course we didn't have consent already. So these are babies that didn't have antenatal consent, and we decided we wanted them to be included because otherwise there would be a much higher proportion of babies that would not enter the trial. So given that they'd still be receiving surfactant and receiving the intervention with the second dose and maybe the third dose of surfactant, which we'll come to, we wanted to enroll them. And so I guess that's important when considering these results and when comparing the results of PLUSS to the prior trials and to the upcoming BIB trial by Dr. Ambal, that is a difference in the way we enrolled babies in the PLUSS trial.
Yeah, I saw that there's some consents, or like you mentioned about the getting consent. Some of them are like antenatally, and then some of them are postnatally. I didn't really see the breakdown, but I'm curious to see, what the breakdown looks like antenatally and postnatally. Not sure if you remember, yeah.
I can't remember the exact numbers, but I think they were mainly postnatal. So this was fairly intensive consent process. We were often consenting families in the hours after birth, and sometimes even sooner than that. Like I remember having conversations very early on in the NICU with some mums and dads. So it was mainly postnatal. By allowing infants to remain eligible to this trial after they'd received surfactant, what that did is it gave us a longer window to consent as well. What we said in the trial protocol that you might be mentioning in more detail shortly is that they'd remain eligible they'd be reviewed 6 to 12 hours after their first dose of surfactant. So in that group of babies, we had longer in which to get consent and could wait a little bit before speaking to families. So it was quite resource intensive getting consent for a trial like this. And I guess that's why I'm so proud that we were actually able to do it in the end, because of that reason. Just one more point, which is you'll note that babies who are on non-invasive support were eligible for this trial. And again, that's a big difference compared to prior trials. These were babies who might either be becoming more unwell with respiratory distress syndrome, so going to be intubated, or, as was the case in some babies, they were going to receive surfactant via LISA or MIST techniques, so they were eligible.
Yeah, must be definitely challenging to get all those antenatally consent. Yeah. All right, moving on to exclusion criteria. So if those infants receive more than 1 dose of surfactant prior, they will be out. And those who receive postnatal steroid for prevention of lung disease, they will be excluded as well. But if you get like a hydrocortisone for blood pressure, they'll stay eligible. Other criteria are more like, common criteria that we use for most of our RCT, like, lethal diseases, major congenital anomalies, they're unlikely to survive, especially those are affecting the lung pulmonary function, such as like severe pulmonary hypoplasia. And then one last criteria is more like logistic reason. If the infant is being transferred to non-participating NICU within the first day of life, they will be excluded. This is the recruitment flow chart. So the team has started out with 2,800 extreme preemie, and after applying the exclusion criteria, 560 were out. When you look at that, 420 of them are receiving non-invasive support, and they didn't need surfactant. So 420 out of that 2,800, which is only about like 15%, are not receiving surfactant. So 85%, like huge number of percentages are receiving surfactant. So something to keep in mind, like the study is looking at the population with high use of surfactant. So after that exclusion criteria, the team has left with 2,200 around there, and then 1,200 were excluded again. Those are more for like logistic reason, right? Parent refuse, parents are not available to get consent, physicians not available to take consent, etc. So left with 1,062, and some consent were withdrawn, and then finally left with 524 in the intervention group and 535 in the control group. And one thing I want to mention is 4 infants in each group didn't receive what they intended to receive from the beginning, but the team has moved forward with intention to treat analysis for the rest of the study, so which is the ideal thing to do in the RCT. Generally, I don't know if you have like other things to share, experience and challenges throughout this recruitment. We talk, I think we cover most of that, but if you have any other things to add, yeah.
Well, of course, the trial recruited straight through COVID, so that was one of the challenges, but we managed to keep going. If you just go back to the previous slide, just briefly, you pointed out that some families declined. In the second box down there in the excluded, 1214 excluded, 379 declined. That's pretty good, isn't it? Like, despite being approached for consent, often with a really sick infant, either prior to birth or soon after birth, it's just amazing, isn't it, that so many families are willing to contribute to research, even in this situation. And I point that out because research is hard, but it's not impossible. And if you ask families and you explain the importance of your trial, we see a strong willingness to participate in our part of the world. And so that's just a really nice thing to point out, I think.
So in our part of the world, we don't have quite that good response. It's generally around 50% or fewer who consent to a trial such as this.
I wanted to ask on this, if we stick on the construct again, you pointed out the maybe 15 or so % who didn't get surfactant, which is actually a fairly small number, I think, reflecting like non-invasive forms of surfactant administration, as Dr. Manley pointed out. that kind of puts this trial. So the questions for both Dr. Manley and Dr. Watterberg, because I feel like the population is then sort of somewhere in the middle between the Htay trial, which was, both unique in that it was the instilled steroid compared to prior prophylactic steroid trials, but also selecting like a very sick population. And then on the other end of the spectrum, we had the prophylactic, Dex and hydrocortisone trials that, we're giving them to all babies, whereas this kind of sits in the middle. And how do you think that impacts the sort of potential benefit of the therapy in combination with the way you're delivering it too?
That's a good point, Brian. I mean, yeah, I think this is what we need to tease out, and it is quite complicated. And I was giving a talk recently on steroids in overseas, and including Kristi's trials, and it's just there's so much information coming out about steroids, and you've got all the different trials, the meta-analyses, the individual patient data meta-analyses, now the meta-regressions, and the many different reviews and meta-analyses with similar but sometimes slightly differing conclusions. It's getting hard to know where this all sits and who to trust. But just specifically on intratracheal budesonide, I think you've sort of got it right there. The Htay trial and some of the other trials were looking at quite sick babies, but who were a bit more mature and a bit bigger. This PLUSS trial is, as you'll get to in the results, all the little tiny babies, but they're not as clinically sick at the time of enrollment, although that's of course not necessarily where they end up. So yeah, it's just important to always consider the context, isn't it? And there's certainly still some work to be done with intratracheal budesonide and surfactant. Certainly keen to hear the results of the budesonide in babies trial that we'll probably talk about later at PAS, and then a group of us are already planning to look together at whether we can personalize this treatment a little bit more.
Just one note on regressions, meta-analyses, meta-regressions versus randomized trials. There was an article looking at adult literature several years back, which found that of the meta-analyses that were done, about a third of them had randomized trials that were done after that did not agree with the outcome of the meta-analysis. I think meta-analysis is really iffy in many cases. I feel better about an individual patient data meta-analysis than an aggregate one, but I think it's still important to understand it's not the same as a randomized trial.
Yeah, one of the slides I talked about in that I added to that talk was the old evidence pyramid that has meta-analysis of RCTs at the top, and this intratracheal budesonide story is a great case study of what do you believe? Do you believe the meta-analysis, or do you believe one or two or three large, well-conducted randomized trials? And I'm sure we're going to discuss that more at the end, so I'll just leave that for the moment.
I think this is such a good point. Yeah, I always think meta-analysis is the best, right? But definitely great point. All right. So yeah, pointing out that I just forgot to mention about that the team has planning to recruit up to 1060 infants, so they were able to achieve what they were hoping to achieve. Just to get the 90% power with the absolute increase in survival without BPD of 10%. So I think that's clinical importance is clinical significance is also important. Looking at some baseline data on mom, looking at the ethnic backgrounds groups, so majority of them are Caucasians, followed by Asians, and those are self-reported from the mom. So those are really important to future application. And other thing to point out is most of the infants in the study got exposed to antenatal corticosteroid, almost around 95%, but only about 65% of them got the full course of antenatal steroids. And one other factor is the maternal chorioamnitis. I think this is, equal number between the two groups, but it's always one of the risk factors that leads to BPD, as well as most of the previous steroids trial whether the mom has chorionitis or not can matter the steroid responsiveness. So I think this is another good factor to include while we're studying for our responsiveness to intratracheal budesonide. Looking at infant baseline characteristics, mean gestation age for here is a little bit more immature than the YA trial, 25 and 6 mean gestation. Birth weight is also a little bit slightly lower, 775 versus 850 in YA trial. And 55% of them are male. And a couple of things to point out here is age at the randomization is 5 hours of life. So one thing we don't see in this table is age at the time of first intervention. But in my next slide, like when we talk about method, Dr. Manley also mentioned about it. The first intervention was given as soon as possible after the randomization. So we're talking about like 5+ hours. But then the other group who already received surfactant, prior surfactant dose, the team will be waiting until like 6 to 12 hours to reassess whether they need the second dose of surfactant to give it together with the budesonide. So those kids would be a little bit later in the age. We're talking about like 6 to 12 hours of life. So you might probably
right. Yeah, you can expect that there were 2 groups here really in terms of the time of the intervention, which averaged out at this median. But actually, when there was antenatal consent or very early postnatal consent to babies that were on non-invasive support, they would have received the intervention in the first hour of life, whereas that's balanced by the babies who'd had prior surfactant that would have received the intervention somewhere between 6 and 12 hours of life. So that's actually what you're seeing here. One might argue that we could have or should have presented both of those values perhaps to show that there were 2 different groups.
Yeah, so a little bit over half of them already received the prior surfactant. So we're looking at a little bit 2 different groups in terms of the timeline. One other important point is the FiO2 requirement immediately prior to the intervention is average out around 30% in both groups, which is significant difference from our previous YA trial, which is about 50 to 60%. So methods wise is we already talked about informed consent. So this is a web-based randomization with 1:1 allocation ratios, and stratification factors were included during the randomization, such as gestational age, sex, SGA status, prior whether they received surfactant or not before, and mode of residue support like invasive, non-invasive, and then maternal chorionitis. Those are all pre-specified. I'm gonna bring those factors back in when we talk about subgroup analysis. So you're gonna see those factors again. And in terms of trial, again, intervention group would be intratracheal budesonide mixed with surfactant, and then control group would just receive surfactant only. And where did they receive those intervention? Either DR or NICU, and double blinding was done by 2% intervention team, which is separate from the treatment team. I think this is an ideal way to do, to get the full double blinding. And just like we talked about, 2 doses in total. First dose is as soon as after randomization, and second dose would be 6 to 12 hours, the first dose. And how much are we giving and what's surfactant? This is a porcine-derived surfactant, which is a Curosurf that we commonly use in US and Australia. The dose is 200 milligram per kilo, so which is the same as 2.5 mil per kilo, that like how we remember. And subsequent dose will be half of it. And budesonide dosing is 0.25 mg per kg, the same as the previous trial. And all the I might probably just ask this question now, Dr. Manley. I'm wondering like why you and your team like decide to stop it at second dose, especially like YA trial goes all the way up to like 6 doses.
Yeah, that was somewhat arbitrary, and it always leaves you with another question. And this is why doing randomized trials that take 5 or 6 years to complete is a problem. If you look at the A trial, whilst up to 6 doses of surfactant or the intervention was permitted, the average was around 1 to 2 doses with a dramatic effect on the primary outcome. At the time we were designing this, we also had some of our friends telling us that the dose of budesonide might be way too high and causing other problems. So we had to balance that, but the truth is we don't rightly know yet exactly the dose of this intervention that might be effective. But again, there's little difference between the Yay trial and what we've done, because we systematically gave at least 2 doses of to babies that were mechanically ventilated, whereas they had other dosing rules that meant that on average the babies got 1 or 2 doses. So I don't think there's a big difference in the dose. However, could we have got the incorrect dose? Yes. And I see, just related to this, Sai on the chat has said, you know, can we actually comment on how we think that 1 or 2 doses of some drug given in the first minutes of life is really going to have an effect on death or BBD measured, you know, 3 months later? And I think that's a good point. A multifactorial condition like BPD, can we really expect a small dose of steroid given this early, given everything else that happens to babies, prevent BPD? Of course, the counter argument to that is we'd seen it. There were trials out there saying that this intervention halved BPD when given as we've similarly to how we've given it. So I think the trial needed to be done regardless.
On the topic of the dosing, I saw Dr. Watterberg kind of nodding a little bit about the dose of budesonide. I'm not a steroid expert. What do you think about, when we start thinking about hydrocortisone versus Dex versus budesonide, and then we're also changing the route of administration, and that's going to affect, absorption. Like, where does this dose sit for people who have no sort of prior knowledge about it?
I think sort of the long history of steroids in babies is that we have done things without knowing what we're doing. And I'm impressed with Phil Ballard and Alan Jobe and their group looking at intratracheal administration of budesonide and what systemic effects you see and for how long you see it. So I just think we're stumbling around trying to figure out what to do.
That's a very fair answer, Dr. Water. Moving on to how we give those surfactant is the intervention treatments are through the ET tube, but I think that's another difference with the YA trial. So for us, for this PLUSS trial is, if they're intubated, it would be just standard way of giving through the ET tube. But if they're on non-invasive, LESER method is also eligible for this PLUSS trial in particular. And in terms of post-randomization, inhaled or nebulized steroids are not permitted until the primary outcome was assessed. So up until 36-week PMA, they can get inhaled or nebulized steroids, but they are allowed to receive systemic steroids according to the local guidelines. And all other management will be at the discretion of clinical team. And then coming on to primary outcome assessment. So the team will be assessing the survival without BPD at 36-week PMA. So assessment happened between like 36-week to 36 and 6. And this is the definition that the team had choose to define the BPD. So one or more of the following criteria. So if they're intubated on the ventilators or other non-invasive like CPAP and IPPV, high flow 2 liter and above, regardless of FiO2 requirement, they will be defined as BPD. And if they're receiving a little bit less support, like high flow, less than 2 liter high flow and below, the team will look at the FiO2 requirement. If it's more than 30%, they will be defined as having BPD at that assessment time point. And if they're receiving less than 30% and support is less than 2 liter and below, they will have to go through sort of like air rejection trial. I think it's trying to see like their oxygen dependency, I suppose. So would you mind sharing, Dr. Manley, why you and your team has like decided to choose this physiologic BPD definition among all the other definition that we have for BPD?
Wow, that's a good question. Let's start with choosing BPD at all. I mean, this trial was designed in 2016 when all trials were using an outcome, or many major trials were using an outcome of death or BPD or survival-free of BPD, including the other intratracheal budesonide trials. So we felt that we needed to align with those to see if we saw the same effect. In designing new clinical trials, I'm not going to use death or BPD at 36 weeks post-menstrual age anymore. I'm thinking much more about respiratory outcomes that are more important to families that might be measured later on, and especially if we're including 22 and 23 and 24 weekers in our trials, the vast majority of those babies have BPD at 36 weeks by our standard definition. So I'm not sure that trying to reduce that is going to be very successful in a baby who's on a ventilator for months. So that's one part of the answer. And the second part of the answer is that we felt this was a robust BPD definition, but as you'll see, we've also in our secondary analyses included the Jensen criteria for BPD as well, which was becoming the accepted norm at around that time. So yeah, I think that's all I have to say.
Just to note that one of the other abstracts that will be presented at the PAS is the hydrocortisone study 5-year outcomes, including functional outcomes, and a subset of those babies, 100 of the babies from the hydrocortisone trial, 100 babies from the top trial who did not have BPD, and 100 normal term baby deliveries will have their pulmonary functions evaluated at age 5 to 6. So I think that's going to be a really interesting outcome that we haven't seen before.
Yeah, that's going to be fascinating, Kristi. And, you know, when doing a big trial like this, the other thing we always think about is what else can it tell us? And we're almost completed the 2-year follow-up of the babies in the PLUSS trial. And one of the things I'm very keen to look at is which definitions of BPD are going to be most aligned or predictive of longer term outcomes in the about 90% of babies that we've assessed it to. So I'm looking forward to seeing what that tells us.
Thank you both for your inputs. This is a statistical analysis. Spark can help me out here. I think it's just comparing the two intervention group by using risk differences estimated by the generalized linear model. And depending on the outcome type, you either use like linear regression or quantile regression with 95% confidence interval. And primary outcomes will be adjusted with the stratification factors that I mentioned before during the randomization, and secondary outcomes were not adjusted for those stratification variables. Wonder if any comment before I move on to the primary outcome. All right. So this is the primary outcome that everybody been waiting for. So the result was not, you probably noticed from the approach that Dr. Manley was talking about the trial, the result was not as positive as the team had expected, just like you see here. So the survival without BPD at 36-week PMA, it's 25.6% in the intervention group versus 22.6% in the control group with the adjusted risk differences of 2.7%. When you look at the breakdown of the primary outcome element, about 83% of them survive in the intervention group at 36-week PMA versus 80% in the control group. And among all those survivors, BPD rate is about 70% in both groups. Dr. Manley, you and your team, how did you feel to see like a first result, finally got the result?
Are you really going to make me
Don't
read
mind
it?
sharing, yeah.
I was so disappointed, so disappointed. I was really hoping that we would find something that could be useful for us to help with BPD. There's a lot in this, isn't there? Firstly, the rate of BPD, traditionally we used to say 50%. And just a reminder, of course, this is not the rate of death and BPD in all extremely preterm infants born under 28 weeks. This is the rate of death or BPD in the enrolled infants. that does not include many 27 and 26-week infants who were never enrolled in the trial, never eligible, never sick enough. So that's important to point out. But when you enroll a group of high-risk immature infants, and we had hundreds of babies under 24 weeks in this, under 25 weeks in this trial. So, we're very pleased to enroll such high-risk group. This is what you get, a high rate of BPD and a mortality of 20%. So, yeah.
We can commiserate having both done large trials and being very disappointed at the outcomes.
Yeah.
Did you look at, well, no, you had a different way of doing the therapies. The thing that we saw in the hydrocortisone trial was that kids who got hydrocortisone were more often extubated during the therapy period. And that was not our primary outcome. And that, it's not in very many days, but the question is that useful? Is that valuable? And I don't think we are coming to that conclusion.
Yeah, well, we'll see the secondary outcomes in a minute, but yeah, we certainly tried to include all the outcomes we thought could lead to a change in practice and were potentially important, but I'll leave that to Dr. Aung to talk about.
All right, coming on to secondary outcomes, I'll just point out, and all those interesting things. So most of the BPD in the groups are grade 2, according to the Jensen criteria, equal distribution between the two groups. And notably, intratracheal budesonide did not reduce the requirement of postnatal systemic steroid. They're about the same. I think one other thing I'm curious about is, like 33% of them received the systemic steroid postnatally. What is the breakdown like, what percentages received those systemic steroid before 36-week PMA, before our primary outcome assessment? I don't know if you remember.
We do have the date that the first systemic steroid for treating evolving or established BPD was given. Whilst I don't know the exact date off the top, postmenstrual age off the top of my head, the standard practice in all participating units was for sick babies with evolving BPD to commence steroids, nearly always dexamethasone, in that sort of 2 to 3 week period after birth. So nearly all of this or all of this would have been given prior to the primary outcome. And as you can see, there's absolutely no difference in the rate of that clinical decision.
It's almost exactly the same percentage that we saw in the hydrocortisone trial who got subsequent dexamethasone therapy.
What about Dr. Manley, what Dr. Watterberg mentioned, like duration or timing of extubation? And there are some trials that, when you talked about patient-centered outcomes, that even within the hospitalization are becoming more interested in something like how long an ET tube is in place, because that's something that parents may intrinsically value the removal of more than a BPD outcome. I didn't see it in this. I don't know if it was in a supplement that I maybe missed.
Might be on the next slide, Dr. Aung. I'm not sure whether you've got the duration of mechanical ventilation and non-invasive.
There we go.
Yeah.
Yeah, there's some days. Yeah. So yeah, the intratracheal budesonide did not reduce the duration of mechanical ventilation or length of hospital stay or number of infants going home with oxygen. None of them were differences between the two groups. So
go back again 1 second, Dr. Aung.
sorry. Yeah, sure.
Just when we're talking about a definition and a diagnosis of BPD, the postmenstrual age at cessation of positive pressure support, third from the bottom, is 37 weeks. So, we need to be really thinking about how and when we define what we're going to call BPD. Clinicians are making a decision to leave babies on respiratory support for longer than they have before. And now there's even studies out there saying that might be a good thing, as you've heard about. But particularly, in this part of the world, nasal high flow is being used a lot more. And the BPD definitions include that as respiratory support as they stand. So if you choose to leave a convalescing baby on a bit of high flow, nasal high flow, while they're learning to suck or whatever, or in a bit of oxygen instead of putting them on low flow oxygen, that's a decision that makes the baby have BPD by our definitions. So it is quite a fraught definition that we're currently using, I believe.
Moving on to, those are like serious side effects from the steroid. So looking at most commonly is hyperglycemia, followed by late onset sepsis, pulmonary hemorrhage, etc. There were no differences between the two groups either. So most of the side effects are look during like first 2 weeks, like 14 days after the intervention. So no significant differences in terms of side effects. So in conclusion, early intratracheal budesonide did not show to improve survival without BPD at 36-week PMA in our extreme preemie. But good thing is there were no safety concern with this intervention. So when it comes to coming on to discussion, is the study internally valid? I would say yes. There's so many reasons. I think Dr. Manley, you and your team has tried so hard all the possibility to avoid, any potential biases, like starting out with like broad criteria to avoid selection biases, and standard ideal double blinding to remove all those observer biases, and also intention to treat analysis that we mentioned, and well assessment, pretty good assessment for the primary outcome. So I think all in all, I would say yes for the internal validity. I think bigger question is the study generalizable? Is the study externally valid? I think it's a challenging question to answer. So I made a little comparison table between positive YA trial and negative PLUSS trial. Starting out with trial size, so the PLUSS trial is 4 times larger than the YA trial. And in terms of characteristics of the infants involved, we talked about a little bit about it. So PLUSS trial has a little bit more immature baby, 25 and 6 versus 26 and 5, also smaller baby, 750 versus almost 850. And then other big factor is their oxygen requirement at the time of intervention. It's like twice, and different surfactant. And the route is also different. YA trial is all intubated, so through the ET tube, but in PLUSS trial, LESER is also allowed. Doses, we talked about it, 6 doses versus 2 doses. And then average age of steady drug is also a little bit later in our PLUSS trial. So I kind of pointed out to like early, more frequent doses of budesonide, would it give us positive result? We don't know. Not just looking at intervention groups, looking at the control group as well. So in PLUSS trial, infants are, higher mortality, higher incidence of BPD among those survivors. So I don't know, it's just like a 2 different result, because maybe we're just looking at totally different 2 groups of population with the different characteristic. Yeah. Anything else that you want to add, Dr. Manley or Dr. Watterberg? Everybody, Dr. King, Dr. Jane, yeah.
Are you going to talk about the subgroup analyses at all, Dr. Aung?
Oh, yeah, this is actually my next slide.
Mhm.
So yeah, this looking at those like stratification factors, applying into the subgroup analysis, there were no differences between earlier 22 weeker up to 25 and the a little bit older, no differences. Motor residue support, no differences. Choriamnitis, SGA, gender, no differences. But we have a little signal right here, which is the FiO2 requirement prior to randomization. This is the total numbers. So for those infants who require more than 50% of FiO2 prior to randomization, there is a 20% survival without BPD versus 12% in the control group. So there was some adjusted risk difference of 10% with the p-value of 0.07. So we have a little signal there, but not the super strong signal. I believe this is not the pre-specified factor. Is that correct, Dr. Manley?
Yeah, we did not plan this sub-analysis, and we were asked to add this by the journal and the reviewers. That went back and forth a little bit, and in the end, we agreed. We just have to be really, really careful here, although clearly this is interesting because some of the prior trials that have shown such a big difference in the primary outcome have enrolled patients with a higher FiO2. This is post hoc. This has smaller numbers of babies in this analysis. And so we just need to be really careful, and the p-value for interaction is approaching significance but is not significant. So there are many reasons to be careful and conservative in our interpretation of this. Having said that, it's a signal that we will explore in individual patient data meta-analysis. We'll wait and see what the BIB trial from the States shows, and we'll see whether we can look at some of these subgroups.
Dr. Watterberg, a question for you. So on chorioamnionitis, the signal is actually pretty dead center, which is different from what you have seen with your studies. Do you have any thoughts on why this could be? Or
Well, we were looking at a whole different milieu. I mean, we were giving the low-dose hydrocortisone systemically, looking at maybe its effects on systemic inflammation. We were giving it over a period of, depending on the study, between 7 to 15 days. And so I think that there's just a very different approach.
Doctor, do you have any, before we go, I'm just gonna launch a poll for our audience, and then we can move towards wrapping up the sessions once those are answered.
Okay, and I would like to show one slide.
Yeah, sure. Go ahead.
Do you want to finish up your
Stop
slides
sharing.
and then
Sure, yeah.
because I think you might have a couple more.
Yeah,
and then Dr.
I
Watterberg
think
can share.
we talked about most of that, and then this is just like a little thoughts. If you were in a YA trial that continue to use the intervention following the positive result, would the PLUSS trial change your practice? I think the poll will answer that, some part of it. And then Dr. Manley mentioned about the BIB trial that's happening in US. These criteria are pretty similar, except the fact that those infants who already received prior dose of surfactant won't be included in this trial. So that would be interesting to see.
That's
I think that's all I have.
important
Yeah.
If that is how it would be used in clinical practice, isn't it? If budesonide with surfactant was effective, we'd give it with the first dose of surfactant. So whilst we didn't show any differences in our subgroup, and we looked at that, of course, we'll be very interested to see the BIB results. I just make one more point. Ye and colleagues completed another randomized trial of steroids and surfactant using Curasurf or Paractin Alpha, as we did, which was presented several years ago at PAS, and in that presentation had similar effects to their prior trials. And we await the publication of those results. So we'll see what they found in their next trial.
Dr. Watterberg, while you pull up the slide, may I ask a question to all of you?
Go ahead, sir.
Okay. Thanks, Dr. Aung, for your presentation. Thanks, Dr. Manley and Dr. Watterberg, for your expertise. Another question in terms of homogeneity or heterogeneity of clinical practices. We do see that even within US, from center to center, there is significant variation in terms of certain practices that we know affect PPD, like use of management of PDA and also postnatal corticosteroid usage, dose, timing, total cumulative doses, extubation practices, and also some practices that we know that can impact PPD have some homogeneity, especially caffeine. Looking at the numbers in the trial, in the secondary outcomes tables, the use of like vitamin A numbers and also some of the caffeine numbers seem slightly lower than the practices compared to here. Can you comment on whether those differences were between individual centers that were a part of the trial, or all the trials included have similar practices, but it was just practice variation? and how it impacted the outcome?
Yeah, well, we haven't looked hard at how it might have impacted the outcome. I mean, as Dr. Aung mentioned, there were 21 centres in this trial. Mainly those were between Australia and New Zealand, with about half from Australia. We had Edmonton involved in the trial and Singapore, so they will have had quite different practices. Overall, especially in terms of sort of use of routine type medications, Australia and New Zealand are well aligned. I can't remember the caffeine exposure that you're referring to. Is it on the screen there?
I see vitamin
65.
D. Mm.
I'm trying to think of the context of caffeine. All very preterm infants in Australia and New Zealand would receive caffeine. Where was that?
It's under table 1, under maternal and infant
Yeah,
baseline
so that will have been prior to randomization, I think, Si.
Oh,
That would have
prior
been,
to.
yeah, that would have
Oh,
been
got
prior
it.
to
Got it.
randomization. Yeah.
Got it. There you go. Yeah.
Yeah,
Here.
yes. These are prior to randomization, but are not indicative of infants receiving caffeine. That would have been 100% if you ask the question of infants receiving caffeine through their admission stay. So remembering that some of these patients were enrolled, were consented antenatally or very early postnatally, they will have received the intervention before they received caffeine. So this was at the time of randomization. The use of vitamin A is very low. In our part of the world, the use of inhaled corticosteroids is much lower than in other parts of the world. There was only 1 or 2 centres routinely using those. And as you can see, bronchodilators also a much lower rate of usage than in other parts of the world. How that affects outcomes, I guess you need to think about your own centre and whether these results are generalisable or not. But you know, the evidence for all of those other things is also needs to be studied. So I can't answer that perfectly.
Thank you.
You're muted, Dr. Watterberg.
If no one minds, I have a question for Kristi. I'd just love to know where she thinks things are with prophylactic hydrocortisone, and whether, you know, benefits outweigh risks at this point, whether we need more evidence or what you're thinking about that, Kristi.
You have to unmute Dr. Watterberg.
You're still muted. Yeah.
Lost the button.
Ah, you did it.
Ah.
Thank you. That was, I lost the button when I put my life cycle thing up.
Mhm.
So I believe that for early hydrocortisone, we have good evidence that it is effective, and it's time to do a large trial again, because there are many questions about potential side effects that need another trial to be worked out. So I think that it needs a new early trial with a bunch of babies. I think it's the right dose. I think it's the right time. I think that we have, like I said, good evidence that it's effective, but it's not going to be part of most people's practice until we confirm it with another larger trial, if we confirm it. So that I think is what we need to do. And same thing with later dexamethasone. I still think that needs a large randomized trial of 1 dose, 1 population. We still don't have it. We've been working on this for over 30 years. And we still don't have it. So this is just the life cycle of any new therapy, and I adapted it from Ron Poland's original. So you have benefit minus risk. So if you have the new therapy, in general, you see smaller trials that are positive. There are many reasons for that. If it doesn't work, people tend not to report it. It's harder to get negative trials published. And so you see a lot of small, very positive, very happy trials. You have to have a multi-center trial. You can't you can't just adapt it into practice without doing that, or you go down the wrong road. A multi-center trial is either going to be a good overall or bad overall. It's going to have side effects. You don't see the side effects in a small trial. If you have a patient base of 40, 20 in one and 20 in the other, if you have a side effect of a spontaneous GI perforation of 1 in one group and 2 in the other group, Is it going to be in the total overall? Is it going to be like, 5 and 10, or is it going to be 5 and 50? You simply do not know that from a small trial. So you have to go through the multi-center trial. And I just think we've done things a lot backwards in neonatology in the way that we've adapted things after very small trials. Dexamethasone is a poster child for what not to do. And we have to go back and fix it.
Yep. So I'll just share the results of the poll. First question was, which is the most frequent steroid used? And almost all of them still use DART, which enrolled only 70 babies, as Dr. Brett reminds us, and still has stood the test of the time in spite of Dr. Watterberg's efforts to bring hydrocortisone on the mainstream and stuff, and even Dr. Manley to bring budesonide here. Many are still sticking with DART, so a lot of more trials still, the answer's not there yet. It's a lot for the young investigators in the audience to work on. And most are still use, as I said, DART, and few use a hydrocortisone, and just one center using budesonide. So very interesting results.
Question for both you, Dr. Manley and Dr. Watterberg, about this need for, because I've heard, maybe it's worth doing another early hydrocortisone trial. It's worth doing another late dexamethasone trial. How do you also envisage, is there a better way to do it to incorporate these different therapies at different time points? Because I think that's going to become a challenge, is if you do one trial of early hydrocortisone, then one question that I'll have is, is that safe in combination with late dexamethasone if they need it? Is there an opportunity to do some sort of some more novel approach like Dr. Manley you're doing with platform trials where you're incorporating these different timings? Because I'm seeing more and more steroids being given across 3-4 months of this baby's early life at different stages, all of which don't have big trials. But even if we have a big trial for each one, we won't have a trial that reflects all of them in combination. And how do we know?
And one of the things we have absolutely almost no data on are the kids who are getting it after all these trials started.
Yeah.
So the kids that are getting it after 28 days, after 36 weeks, we don't know what that looks like. If I could just make one comment on the neurosis trial, the inhaled steroids, it looked like it decreased BPD, although it increased mortality a little bit. But if you look at the two groups that were enrolled, many babies in that trial were not intubated. And so they got their therapy through a mask. They were the ones who benefited. The ones who were intubated, it was like a 2 to 3% difference in the incidence of BPD. So I would say to you that the babies who were getting it through a mask had a lot higher deposition because they were depositing it all through the oropharynx as well as down into the lungs. The kids who get it through the endotracheal tube have very little deposition in the lungs because most of the stuff doesn't get in. What gets in, a lot of it goes right back out because the particles are so small. So I think we need to be really careful in interpreting the results of that study.
Thanks, Kristi. And just to add my thoughts to Brian's question and to your thoughts, I do think we need another hydrocortisone trial. It's a balance, isn't it, between trying to do everything or doing one thing well. If we had infinite patients like we were adult cardiologists, you could do some sort of factorial design. Certainly I'm thinking about a hydrocortisone trial, and I'm also thinking about a prophylactic hydrocortisone trial, and I'm also thinking about the dose and type of steroid given after the first week of life. At the moment, I'm not sure how I can combine the two, but
Right.
if they are both running in an adaptive platform trial, we'll be able to at least borrow and compare a little bit across the different domains and across the groups. And then it gets a bit statistically difficult for me, but that's what I'm thinking at the moment. We're not using prophylactic hydrocortisone. Very few centers are in the Southern Hemisphere. And however, I think it's very promising and needs confirmation.
Yeah, I feel pretty good about the dosing on that because we did do originally some pharmacokinetic work to try and figure out what dose to use. I don't feel good about the doses of dexamethasone because I think that there's very little pharmacokinetic work on the biologic effect of different doses.
Really good points raised by both Dr. Manley and Dr. Work, and a lot of learning points on steroids. The chapter is not closed. There's actually a lot more questions now rather than answers after today's discussion. A lot for the young investigators to focus on. With that, we'll do some closing comments. Dr. Watterberg, to start with, any closing comments for all the trainees?
Just to say what a wonderful job Htay did in presenting this and going through it in a just fantastic fashion. Thank you.
Thank
That was
you.
one of the best journal club presentations I've ever seen, and I'm glad it was about one of my trials, and I may steal your slides. Thank you very much for having me.
Yeah. Thank you for this opportunity. I learned so much.
Dr. Ong, really good presentation. We'll be back again on April 2nd with the PPEX trial. We'll send you the details through the AAP listserv. Thank you so much, Dr. Manley. Thank you, Dr. Watterberg, for your insights. It was wonderful. Thank you.